So I think now I'm okay, let's go from start, square number one. Okay, hello everyone. My name is Alejandro Aldape. I'm the clinical director from Sims IVF here in Klonsky. Will you please just confirm for me that everything is fine, that you are hearing what I'm saying? Can you hear me?
Yes, we hear you clearly.
Okay. And can you see the presentation that is just there, Mohammed, as well?
Yes.
Okay, fantastic. So then let's just start with this. Thank you so much for this opportunity. As always, it's for me a pleasure and honor to join this journal club and have this conversation with colleagues from abroad. My name is Alejandro. I've been working in fertility for 12 years now. I've been working in several countries. Initially, I started in Barcelona back in 2009, and then I moved to Ireland back in 2017. And yeah, so my main area of interest will be poor prognosis patient. I'm previously known as poor responder. So I hope that today you can find some, you can find this presentation interesting. And then at the end, if we can just kind of share some kind of points of views about the presentation, and I will be more than happy to help. So the presentation that we have for today, it is Management of Poor Prognosis Patients. The learning objectives that we have for today as well are, number one, will be to review the evolution from poor responder to poor prognosis patients. So back in 2010, we were calling the patients that they were not having an adequate response to an IVF cycle as poor responders, whereas now 2022, we are more kind of talking about poor prognosis patients. We are going to cover that today. We are also going to discuss the best treatment strategies and options based on the Poseidon group classification. Poseidon group, it's a very, very renowned group of doctors here in Europe that they came with this idea of the Poseidon group that we're going to cover now as well in a few minutes. And also they have designed in this system where we can have clear strategies when it comes to patients kind of falling in the group 1, 2, 3, 4. We're going to cover that today as well. And then the other learning objective will be what the benefits of using a combination of FSH and LH in a 2-to-1 ratio. And we are also going to show this with a case study. So I hope again that you can find this interesting. And let's go and see the presentation. So the background of the poor ovarian response, this first was described back in 1983, okay? And this was described by Dr. Juan Garcia in the Fertility and Sterility, and this was described as a response that wasn't expected, okay? So the poor ovarian response was initially described in 1983. The incidence that we have for poor responders, according to the IVF Worldwide Organization, it's something in between 6 to 20% chances. And of course, because of the fact that women, they are postponing or delaying getting pregnant, it's something that we are going to see more often nowadays. So just to give you an example, back in 2003, the incidence of the diminished ovarian reserve or poor ovarian reserve was calculated at around 10%, whereas now, can you see the presentation there again? Sorry, I don't know if you can see the presentation.
We see now a background of BOR.
Okay, perfect. So then, whereas now 2013, this kind of a statistic or this incidence has been calculated in 18% chances. Okay, so for some reason this is not sharing this. Okay, so when we are talking about this, what is the reason that this is relevant? Okay, the reason why talking about poor ovarian reserve for responders, it is relevant is because definitely, when we are having a patient who is not having a good response to the ovarian stimulation, definitely the treatment can be compromised. And when I'm saying that can be compromised, I'm talking about the live birth rate and also the cumulative pregnancy rate. What you are seeing there on the screen, this is a study that was published in the Human Reproduction back in 2016 by Dr. Dracopoulos, and essentially it is defining where is the cutoff when it comes to not having a good response to treatment. So as you can see there on the chart, it is true that the live birth rate, it is not changing too much when it comes to 10, 15 eggs or getting more than 15 eggs. But at the same time, if you have a look, the cumulative pregnancy rate, which means the fresh plus the frozen embryos that we can get in one IVF cycle, it's completely different when we are talking about more than 15 eggs. And please also note that the patients that they are on the other side of the equation, patients when they are not getting more than 10 eggs, the cumulative pregnancy rate can be compromised dramatically. With, for instance, when it's only 1 to 3 eggs, only 21% chances, or when it's 4 to 9 eggs, only 39% chances. So definitely number of eggs matters when it comes to success rate for treatment. So that is the reason why it's relevant to talk about poor prognosis patients. This was a meta-analysis that was published back in 2010. It is including 14 studies and a total number of 47K of patients. And the conclusions that they got from this meta-analysis are basically these two columns that you are seeing there on the screen. There's negative predictive factors for an IVF cycle, and there's positive predictive factors. And please note that when it comes to the negative predictive factors, definitely one of the most important ones, it is age. And of course, we're going to talk a lot about age during these presentations. And when it comes to the positive predictive factors, again, number of eggs retrieved and embryo quality. Of course, the higher the quality of the embryo, the better the success rate, the higher the number of eggs, also the higher the probability of getting that particular patient pregnant. Okay. In 2011, the ESHRE, the European Society of Human Reproduction and Embryology, they have this big congress in Italy where Professor Lamarca and Ferrati, they came with this idea, as we know as Bologna criteria for poor responders. And in fairness, it was a fantastic attempt to kind of standardize as much as possible what we all doctors have been seeing in our consultations, some patients that they were not responding properly, some patients that we unfortunately only getting 1 or 2 eggs there for the IVF cycle. So they came with this idea and with this criteria for doing the diagnosis. So what you are seeing there on the screen, of course, is pretty much what we know about the diagnosis of poor response patient by the Bologna criteria. So we have advanced maternal age, above 40 years old, previous poor ovarian response, less or equal to 3 eggs, and then of course an abnormal ovarian reserve test with, and they were also saying this, that an AFC, antral follicular count 5 to 7, or AMH 0.5 to 1.1 nanograms by ml, and of course 2 episodes of poor ovarian response with maximal stimulation. They were sufficient to define someone as poor responder. And then finally, patients over 40 years old that we supposed to kind of consider they're more likely to be an expected poor ovarian response. But what I want you to do today, and please don't get me wrong, I have huge respect for all the doctors that they did this attempt. I actually personally know Dr. Lamarca and Dr. Ferrati, so they are fantastic doctors. But please, if we want to see this with kind of new pair of eyes, we need to see where this information is coming from. So the first thing is like, why 40 is defined as advanced maternal age? Why not 38? Why not 42, for instance, or why not 35 years old? What is a conventional stimulation protocol? Are we talking about 150 international units of whatever medication? Are we talking about 225, 187? What is exactly conventional stimulation protocol? So then, are we talking about 5 or are we talking about 7? Because one egg or one follicle could be the difference between getting pregnant or not, okay? What is maximal stimulation? Are we saying 300 as the extra recommendations? Are we saying 450 as we sometimes are using here in Ireland? So what I want, I mean, I'm not criticizing, don't get me wrong, but what I'm trying to say is that when you kind of look to the details, it's just like, it is not clear exactly where these standards or where these criteria were coming from, okay? And then the conclusion in this article and in this assessment that they have done, as you can see, there is the definition presented in this article represent the first realistic attempt by the scientific community, the ESHRE, to standardize and to define poor ovarian reserve or poor responders in a simple and reproducible manner, and of course with the minimal criteria of selecting the patients. But you see, they are also saying that it will be homogeneous population, and then finally that we can develop some tools based on these criteria. But I generally I want to ask you, do you really think that we are checking, that we are assessing homogeneous population with these criteria? Do you think that actually it's something that we can reproduce in other countries as well? And do we have any strategies? Because of course, when it comes to Bologna criteria, okay, we can get to the point like, okay, this patient, it is a poor responder based on Bologna criteria. And then what? What is the treatment? What is the strategy when we have a patient like this? Long story short, what I want to tell you is that, and again, it is not about criticizing, it's just observation piece. But what I'm trying to say here is that when you go deeper and analyze the Bologna criteria, you're going to see that actually we are not talking about an homogeneous group, but actually inside of the Bologna criteria, you can see at least 8 subgroup of patients. What you are seeing there on the screen, this is taken from Professor Robert Fisher personal data, and this was published as well in the Human Reproduction back in 2014. And essentially what you can see there, for instance, I'm very sorry because part of the slide is kind of a very, very faint, but what you can see here is saying no previous IVF attempt, a patient over 40 years old, and abnormal ovarian reserve test. This patient will match the criteria 1 and 3 as per this that we are seeing just here, 1 and 3, okay? So then, 1 previous IVF attempt with poor ovarian response, patient above 40 years old, it is going to match the criteria, it's going to fulfill the criteria 1 or 2. And if we continue, you can see that, of course, according to the definition, 2 out of 3, they were enough to kind of label someone as poor responder according to the Bologna criteria. So you can see, we are talking about at least 8 subgroup of patients. It's not as homogeneous as we thought it is, as we thought it was, okay? So in other words, what I'm going to tell you, or what I want to ask you is this. Let's just say that we have these 3 patients in front of us in our office. A young woman under 35 years old with low ovarian reserve and with a previous episode of poor ovarian response. Then we have a young woman under 35 years old with normal ovarian reserve with 2 episodes of poor ovarian response, but also we have an older woman above 40 years old with normal, again, ovarian reserve and previous poor ovarian response. The question to you is, would you prefer the same treatment plan for 3 of them? Because, of course, as per the Bologna criteria, the 3 of them are matching the criteria of poor response or poor responder patient. But as you can see, it is not the same having a patient under 35 years old compared to having a patient above 40 years old. And both patients are going to be on the same bag of poor ovarian reserve or poor responder. So for that reason, it's just like nowadays, the Bologna criteria, to my eyes, they are a little bit not, they are not updated anymore. Because of course, we are not seen as a single population, but actually it is a subgroup of patients. So then that was the reason why there was an update now according to this, and now we are talking more about poor prognosis rather than talking about poor responder. So yeah, Bologna criteria as poor responders, they were classified as one single population, but actually, as I just showed you today, it's a very heterogeneous group of patients under 35, above 40 years old. They cannot be on the same bag, okay? There is a confusion existing between real poor response to the treatment and what is the cost of that poor response, and we are going to cover that as well today. And again, unfortunately, with the Bologna criteria, we can label a patient, okay, poor responder, but there is no clinical recommendations about what to do with them. This is just a slide to show you why age does matter. And of course, it's very obvious, but what I want to show you here is that age, it is still the best parameter to predict the quality of the egg, okay? So what you are seeing there on the screen, this is a study that was published by Atavaris back in 2012. And the reason why this is relevant is because I want to show you how the aneuploidy rate or abnormal embryos, it is increasing with age, but does not increase with number of blastocysts. And that's very interesting because back on the days, and I remember when I initially started doing IVF, I've been told, Alex, don't do high stimulation. You're going to get a lot of eggs and the quality is going to be poor. And that was a dogma, that was a paradigm that we doctors, we were having for a long time. So for instance, as you can see here, egg donors, it doesn't matter. I mean, of course, donors in Europe, we are talking about patients or donors who are under 35 years old. So it doesn't matter if we are getting 1 to 3 blastocysts, or if we are getting above 10 blastocysts, the aneuploidy rate of normal embryos remains in 30%. And as you can see, this rate of aneuploidy embryos increase with age, but does not increase with number of blastocysts. This is very relevant. And this is crucial to mention to you that nowadays, is still 2022, the best indicator for knowing about quality of eggs remains with age. And age, of course, can define prognosis for patients. Okay, so then the next thing is like, now that we know what is the best marker according to quantity, which is age, so then we need to define what are the best markers when it comes to ovarian reserve and ovarian response. So this was published by Breuer in the Human Reproduction back in 2013, and this is a ROC curve, as you know. So essentially, what gets closer to 1 has better sensitivity to predict how is going to be the response. So then, of course, we can work with age and FSH, age plus AFC, all what you are seeing there on the screen. And please note how reliable is the combination of age, AMH, and AFC with 0.8, okay? I know that still, if we are adding the FSH, is 0.81, and that would be perfect. But for instance, if you have in your clinic age, AMH, and AFC, you are going to do a fantastic treatment plan, and you're going to be a fantastic prediction on what is going to be the response for that particular patient. What I'm trying to say here, it is on one side, we know that age does matter. On the other side, very crucial information to know about our patients, it will be the AMH and the AFC. And of course, having that information updated. We recommend, and something that we are trying to establish here in our clinic, is that for patients above 38 years old, to kind of update the AMH every 3 months if possible. Okay, and then the group that I was telling you before, the Poseidon group, it is a group of very, very renowned doctors. Yeah, so I have the honor to know personally some of the doctors that are there on the screen, but essentially the reason why I'm showing you this slide is just to tell you that this idea of moving from the poor reserve, poor response patient to the poor prognosis is not something really new. This started in 2016, but still the way we are preparing the treatment plans and the way we are classifying the patient, it is new to many patients and to many clinics abroad. So this is the group that I was telling you before, and Poseidon stands for patient-oriented strategy encompassing individualized oocyte numbers. So what this group of doctors, what they are looking is to define the strategies, to define and tailoring the treatment plan in order to get the number of eggs that can potentially lead to an euploid blastocyst. So they are all about personalized treatment, using different GnRH analog regimens, detecting polymorphisms, tailoring the FSH starting dose, and all of this, it is summarized in the strategies, and all of this is summarized in the Poseidon chart that I'm going to show you in a minute. Yes, and they have defined success in a different way. Not only defined as live birth rate, not only defined as cumulative pregnancy rate, but definitely defined with this, the ability to retrieve the number of oocytes necessary to obtain at least one euploid embryo for that particular patient. And of course, this change with age, this change, of course, with several kind of items that we are taking into consideration when we are using the ART calculator. But that's probably for another day. Okay, so they came with this idea. We were saying that the best way of predicting quality is given by age. We also have said that the best way of predicting the response of the ovary is given by the AMH and AFC. So then what they have done, they have defined in 4 groups, okay? And the 4 groups are the ones that you are seeing here on the screen. This was published back in 2016 by the Fertility and Sterility magazine, and it was published by the Poseidon group. So please have a good view about this strategy or this idea of diagnosing patients. So we have there 4 groups. So what you are seeing here on the upper levels will be patients that, at least on paper, we can say that they do have adequate parameters of ovarian reserve, such as AFC above or equal to 5 and AMH above or equal to 1.2 nanograms by ml, okay? And then on the lower side, group 3 and 4 will be patients that unfortunately, at least on paper, we can see that the ovarian reserve, it is not adequate, okay? And we can say that the AFC is under 5 and the AMH is under 1.2. And then if we divide or we split this into 2 columns, we are going to see that group 1 and 3, they are younger patients, and that was defined not as 40 as it was defined in the Bologna criteria, but it was defined as 35 years old according to the meta-analysis that I showed you in the third slide, okay? And then in the group 2 and 4, it is older patients and patients who are above 35 years old. To be honest, nowadays, at least here in Ireland and here in Sims, most of the times we are seeing the vast majority of our patients falling in one of these groups rather than group 1 or 3, okay? However, what I'm trying to tell you here is that definitely the way of classifying the patients as by age, and not only by age, but also by AMH and AFC, it's a fantastic strategy to tailoring the treatment plan and the strategy to maximize the success for the patient. Of course, also in group 1 and 2, we have 2 subgroups as well, 1A, 1B, and 2A, 2B, according to the number of eggs. When it's less than 4 eggs, so that would be, for instance, 1A or 2A. When it's in between 4 to 9 eggs, it will be 1B or 2B, and they have come as well with this definition of suboptimal response. Please, again, pay attention to the age, pay attention of the AMH and AFC, because of course, at the end, we're going to have some cases studies, and there are some questions related to this chart that you are seeing just right now. Okay, so in 2019, Professor also Alessandro Conforti, he defined the best practice for patients who are falling in the Poseidon group 1 and 2. And of course, what would be the management when we are seeing that the response is not what we are expecting? So the name of the article, it is the management of women with an unexpected low ovarian reserve. And of course, it's very interesting because of course, there are several strategies that Dr. Conforti and the rest of the Poseidon group that they are telling us that we can do when we are finding out that this is happening to one of our patients. Number one, the use of recombinant FSH in preference compared to urinary gonadotrophins. Nothing wrong against urinary gonadotrophins. I use urinary gonadotrophins with my patients, but of course, when it's about improving patients that they were having unexpected low response, we try to tailor the treatment and we prefer to use the recombinant FSH. Most of the times is more consistent and slightly more powerful. The increment or the increase of the FSH, the LH supplementation, the use of androgens that can be prescribed as DHEA, that can be prescribed as testosterone gel. There are several ways of doing an androgen boost rather than doing an androgen priming. And of course, the combination of doing cycles back to back. So in that way, we can get more eggs in the shorter period of time. And the summary of that article, again, that was published by Dr. Conforti in 2019, it is that the strategies are just there. So essentially, when we are diagnosed a patient that is falling into the Poseidon group 1 or 2, so then there is 3 things that we need to pay attention to: pre-treatment protocol, ovarian stimulation protocol, and then the trigger, okay? So essentially what they will recommend for patients, and remember please that Poseidon group 1 and 2 are patients that at least on paper, they do have adequate ovarian reserve, okay? For that reason, the AFC, it should be above 5, the AMH above 1.2. And of course, most of the times patients that are in the groups 1 or 2 are patients that they already have done a cycle, because it's in retrospective is when we know that, okay, they were falling in this category. So what they consider before starting a treatment, the ART calculator, as I was just telling you, to kind of not only advise the patient, but also to kind of explain the patient the probability of getting pregnant according to age. So the ART calculator, it is a tool that we are using to tell the patient how many eggs are required in order to kind of achieve that euploid blastocyst that we were saying. And also, they recommend to assess the genotype screening for, of course, polymorphism of the receptors of FSH and LH. And also in some patients, particularly when the testosterone is low, or when the ovarian reserve markers are kind of closer to 5 and closer to 1.2, they also recommend to use an androgen boost. So then we have in the stimulation protocol, we have patients under 35. We do have patients also above 35 years old. So this is exactly what they recommend. If we are having patients that they were falling in the Poseidon group 1, not good response, to increase the dose of the FSH, also considering to add LH. And definitely for patients above 35 years old, to start with a higher dose of FSH, like 300 international units, and try to keep as much as possible the 2-to-1 ratio with the LH of 150. Also consider the duo-stim approach, and that's something that we're also going to cover today. And when it comes to the trigger shot, well, there is 2 regimens that they will recommend. They will recommend, for instance, a GnRH8 trigger. And of course, when you're using that trigger, you have more flexibility. You can start with another stimulation, and also they will consider a dual trigger shot. Yeah, it's also true that they also will recommend to do PGTA when patients are more closer to 38 or above that age, just to be on the safe side when it comes to genetic and prognosis of the embryo. And consider always a single embryo transfer. So when you put all this together, this is the way nowadays, 2022, we are tailoring the strategy and the treatment plans for the patients that we know that unfortunately they did have an unexpected low response to treatment. Okay, and what about for groups number 3 and 4? Because again, this is covering groups 1 and 2, and then we have also the groups 3 and 4. The problem here with the groups 3 and 4 is the ovarian reserve. That's very clear, okay? So we unfortunately cannot overcome the ovarian reserve with increasing the dose. So it's not about these groups 3 and 4. It's not about from 300 going to 350 or 450 international units, because the outcome is going to be pretty much the same. We cannot overcome that, okay? For that reason, for groups 3 and 4, what the Poseidon group it is recommending will be doing a blastocyst accumulation or oocyte accumulation. So basically an accumulation strategy. Also, they will recommend to do the dual stim. And talking about the dual stim, this was published by Filippo Ubaldi back in 2015. And this is pretty much the protocol that we are using nowadays in many clinics when it comes to doing a dual stim. Essentially, the dual stim, it is about doing 2 antagonist treatments back to back, okay? So essentially what we do with the menstrual period, we start with medication, 8 to 10 days, we trigger with an analog, and then of course we do the egg collection, okay? And 5 days after the egg collection, regardless of the menstrual period or not, the patient start with the second stimulation, which is pretty similar to the previous stimulation. So is 2 treatments back to back together, and pretty much it is the same dose and the same medication that you're using in the first stimulation, you're using it in the second stimulation. Nowadays, again, this was defined, and this was one of the first strategies that was described back in 2015. Nowadays, there's several ways of doing this. With buserelin trigger, we dual trigger the last stimulation, using progesterone, medroxyprogesterone, rather than using the antagonist treatment. There is a lot of ways of doing the dual stim. None of this has proven that one is better than the other one, but definitely the indication for doing the dual stim, it definitely will be a patient which is on the Poseidon group 3 and 4, but also patients where getting one egg could be the difference between getting that patient pregnant or not. And at the same time, when we have the urgency of get as many eggs as possible in a short period, in a short window of time, for instance, oncology patients. Okay, so let's just try now to do this case study. So I want all of you to pay attention today. So essentially, this is a real case study, a real patient that I had 3 years ago in another clinic, and you have the information here. So let's just talk about this patient for 1 minute. So we are talking about a 37 years old female and partner 39 years old that they were trying to conceive for 3 years. On the background, there was the diagnosis of endometriosis, stage 1 or 2, with no active treatment. The patient had an appendectomy during childhood, and she did have a lapandi in 2016, which was showing right tube not patent and the left tube was patent. So in the gynecology and obstetrics, menstrual period, fairly normal, 27, 32 by 4 days, no previous pregnancies. And then again, please pay attention to the age, 37, AMH 16.8, this is the units that we are using in Ireland. I'm not familiar with the units that you are using there, but it's also in nanograms by ml. This will be 2.35. The AFC 16, good number. So then the SIS tubal left tube pattern, just similar to what we have found before in the lapandi. And then the semen assessment, good volume, sperm concentration, motility, morphology, DNA fragmentation, 12%. So then when they came to my office, they also told me that they have done 2 sexual intercourse with letrozole or TSI with no success. They also have tried 3 IUIs, okay? And then they also have tried an IVF cycle, long protocol, and where we were able, that was in another clinic, by the way, and they were able to retrieve 8 eggs, 7 fertilized, and then 1 embryo transfer, 4 BB, beta HCG positive. So the relevant information here, again, of course, everything is relevant. But for the questions that you're going to have to answer, it will be age of the patient, AMH, AFC, and the eggs that they were retrieved. Okay. And when they came to my office, they were very clear to tell me, please, Alex, we want to avoid as much as possible teen pregnancy. And the diagnosis was primary infertility, unilateral tubal factor, the background of the 1 and 2. So then the first question to you is, given their medical history, which statement best summarizes the couple? Are we talking about an older female, Poseidon group 2, and the main problem is the number of eggs left as per the ovarian reserve markers? Are we talking about a Poseidon group 2 patient? The main problem was the hyper response to the IVF cycle. Are we talking about a Poseidon group 4 patient? The main problem will be the endometriosis stage 1 and 2, which is affecting the egg quantity. And then finally, an older female, Poseidon group 4, the main problem is embryo quality as per the high DNA fragmentation. So just going to give you 10 seconds. So if somebody can tell me what the right answer is, so then we can move to the next question. Okay, so 10 seconds now. I don't know if somebody wants to tell me what you think is the right answer. If not, there's no problem. I can tell you what the right answer is. So is there anybody that wants to tell what the right answer is? Okay, we have somebody in the chat. Perfect. Yes, the right answer is B. And we just go with that. Let's go here. Fantastic. Yes, so she is a Poseidon group 2 patient. The main problem, of course, is the hyper response to an IVF cycle, because just remember, we got only 8 eggs, and only 8 eggs from a patient that has an AMH of 16.8 or 2.35, an AFC of 16. It's something there that is not matching, okay? So yeah, so the patient is a Poseidon group 2B. So she classified as a Poseidon group 2B because the number of eggs that was suboptimal. We only got 8 and we were expecting to get higher number. So given again the medical history, what would be your approach to treatment for this patient? Letter A. Patient has one fallopian tube patent. She is under 38 years old. Therefore, we can just try something different, like performing an IUI. Or are we saying patient had a suboptimal response to an IVF cycle, given her age, perform another IVF cycle, changing the medication and adding recombinant LH? Are we saying then, oh, patient had a poor IVF cycle and poor embryo quality, given her background of endometriosis? Are we going to consider egg donation? And finally, letter D, patient had an implantation failure because of the transfer that she did. So then therefore doing an hysteroscopy and then to perform an IUI treatment. So then again, 5 to 10 seconds, you can answer that question. You can send me the answer by the chat, there is no problem, and then we can continue. Okay, we have the answer again. Yes, the right answer again will be the letter B. We are talking about, of course, a suboptimal response to an IVF cycle. And of course, given her age and given the previous cycle that she has done, the recommendation will be to change the medication and adding recombinant LH. And that was exactly what we did. So essentially, what I did is like, okay, she was falling in the category 2B, as we just mentioned. So I took this table coming from Conforti article, and what we did is just to try to follow that pre-treatment ovarian stimulation and trigger shock. So for instance, in Ireland, it's not so easy to access to a kind of a genotype screening. So for that reason, we just did an empirical approach, which is just to increase the dose of the medication and changing the medication as well. I have suggested quicker, but because of the fact, I mean, the patient wasn't so keen to go ahead with that. And the other thing is like, well, her her markers, the AFC and also the AMH, they were okay on the okay side. So for that reason, there is no particular benefit of having the androgen boost. So then, of course, for the stimulation protocol, instead of only using FSH as she did in the previous protocol, I changed the medication using a recombinant FSH and also a recombinant LH. And getting to this point, I really also want to highlight this. And this is a new marker, a new index of efficacy when it comes to treatment. The name of this one is follicle oocyte index. This was also defined by Dr. Alessandro Conforti and Professor Carlo Albigi, and it was published back in 2018. And essentially what it's trying to assess, it is the relation in between the follicles that we can see during a baseline scan and the follicles that we are retrieving on the egg collection. This is relevant because, of course, when we are seeing that the FOI, it is under 0.5, under 50%, so then the likelihood is that the patient, it is a hyper response. Please also note that the follicle oocyte index can be affected by low gonadotropin starting dose, can be affected by genetic or environmental factors such as the polymorphisms of the receptor, can be affected as well the number of eggs that we are retrieving and therefore the FOI because of asynchrony of the follicular development. And then finally also can be affected the FOI during the egg collection, having problems to reach one of the ovaries. But if all these four that you are seeing here as pathogenesis, they are covered, definitely a low FOI follicle oocyte index, it is suggestive of an hyper-response patient. This is important because now the way I assess my own treatment plans, the way I is taking this into consideration. When I'm doing the review consultation, when I'm talking to the patient, I'm seeing, okay, how many follicles we have seen during the AFC baseline scan, how many eggs we have collected, so then I can calculate the point. Because with this and previous medical history, you can also diagnose when a patient it is falling in the Poseidon group 1, Poseidon group 2, and therefore you know this algorithm to follow. Okay, and this is a strategy to maximize the outcome. Okay, question number 3. What would be your preferred protocol for this patient? And then again, are we talking about a long protocol with GONALEV 300 international units transferring 2 embryos on cleavage stage, an antagonist protocol for ovaries, which is a combination of FSH and LH transferring 1 embryo on the blastocyst stage, an antagonist protocol and increase the FSH dose with the same medication, but this time around transferring 2 embryos? Or are we talking about a long protocol with per ovaries again, 150 international units transferring 2 embryos? And please, again, just 5 seconds if you can tell me what the answer is. Okay, yes, is letter B is the right answer. Again, and yeah, so we will recommend, given the fact that patient age, AMH, and previous response with a suboptimal response, Poseidon group 2B, the recommendation will be to do per ovaries because that's a combination of FSH and LH 2-to-1 ratio, and it's very simple for the patients to use. Yeah, and when it comes to yeah, so why we use the antagonist protocol? Because here you have the option of doing the long protocol or the antagonist protocol. But the reason why most of the time we go with the antagonist protocol, remember, her AFC was high, it was 16. So then we can tailor and we can modify the trigger shot if we are seeing that the patient is having a hyperstimulation. Of course, and that's the main reason, the AFC, safety and flexibility. So that was the reason why the right answer, as Mohammed just said in the chat, is the letter B. Okay, so this is what happened to these patients. So we went with that treatment, short antagonist protocol per ovaries 300. This was the cycle day 10 scan. Everything was looking fantastic in terms of the stimulation with the ovaries, but then the P4 was high. It was 2.0 nanograms by ml. So at the end, we changed the strategy to a freeze-all strategy. But number-wise, as you can see here on the screen, right ovary, left ovary. So we went to the egg collection. We collected 14 eggs. From those 11 eggs, they were mature, and then 8 fertilized. So then at the end, we were able to get 3 embryos, 4 BA, 4 BB, and 2 BB. We transfer, of course, a medicated FET, transferring 1 embryo, 4 BA, and she got pregnant and she delivered at 38 weeks without no complications. And as I said to Hala, my good friend, we always present the cases when everything goes fine, right? And yeah, she got pregnant. And yeah, so the summary of the case is, well, consider low FOI, low follicle oocyte index, as suggestive of hyperresponse. We also have seen that the pathogenesis could be related to asynchrony, to not good egg collection, or genetic problems like polymorphism. But definitely when you are reviewing your own patients and you are seeing that the FOI is lower than 50%, that should ring a bell, and that should tell you that potentially the treatment, the medication that was selected wasn't enough or wasn't sufficient, or we need to change the strategy. Poseidon group 2B patients, hyper-responders, could have the benefit of an FSH and LH recombinant medication in a 2-to-1 ratio, as we were just showing during this presentation, and individualized approach considering and respecting the patient's preference is crucial to strengthen the doctor and patient relationship. And this is in relation to the fact that, well, if she is coming to our office and she's telling us that she wants to avoid as much as possible twin pregnancy, of course, something that we will not do is to transfer 2 embryos, but transferring 1 embryo blastocyst stage. And the take-home message is Poseidon Group and related strategies properly address the overview of low prognosis patients. Again, we have moved from the poor responder to the poor prognosis patient. Nowadays, we're using the Poseidon groups because it is a more comprehensive approach. And also because with the Poseidon groups, at the same time that we can advise our patients better, we can define the strategy and we can have potentially, of course, better outcomes. LH supplementation, it is beneficial in terms of both oocyte quantity and quality, okay? And women, of course, with a hyper response, potentially with to FSH clonotherapy, they definitely need to be on LH. The duo-stim, it is a valid option, and this would be for patients who are in the Poseidon group 3 and 4. And again, remember, Poseidon group 1 and 2, patients that at least on paper adequate ovarian reserve, and if there's a suboptimal response, potentially is related to the medication, so you can increase the medication, change the medication. Poseidon group 3 and 4, the problem is the low ovarian reserve, so then you are not going to overcome that with increasing the dose or with changing the medication. For that reason, for Poseidon group 3 and 4, the recommendation would be duo-stim embryo accumulation or egg freezing for accumulation for treatment. And yes, personalized treatment plans and protocol continue to be the best strategy for low prognosis patients, which of course remains very challenging patients. And thank you so much for the attention today. Thank you for attending for this journal club. I hope that you have found value in the presentation. And if there's any questions, of course, more than happy to have a conversation with you.
Yeah, thank you very much, Dr. Alex, for great talk as usual.
Thank you so much, Ala.
Thank you, Dr. Alex. Fantastic lecture.
Thank you so much. Of course, if you want to have this presentation, there is no problem. What I would suggest, if you don't mind, the case study is something that I cannot share, but the rest of the information is actually published there, and it's just a summary. And of course, you can use that if you want to use it. I know that this presentation was recorded, and of course, yeah, there is no problem if you are reproducing this journal club with other people.
Thank you, Dr. Alex.
Is there any questions that you may?
Thank you.
Is there anything else that you want to know? Is there something that you want me to clarify? Is there something that I've been clear about? Is there any questions? Okay, so if there is no questions, so that could be a very good thing, or it could be that it wasn't very clear at all. So I hope it was very clear for everyone. So thank you so much again for your time. I'm Alex. I'm working here in SIMS IVF and Klonsky in Dublin. I'm so happy to have Dr. Hala with us. And yeah, again, if you need me for presentations, if there's other topics that you want me to prepare, absolutely. I will be more than happy to kind of participate with you guys, and you just let me know if there's anything else that I can do for you. Okay. So if there is no question, thank you so much for attending to this journal club. It was a pleasure and an honor as always. So thank you so much.
Thank you very much, Dr. Alex. Have a good night.
Same for you.